once again. So I will be speaking on the retro mode, which is a new instrument or new diagnostic tool in the basket. So it specifically images the RPE. So we all know that RP is outer retinal blood barrier. But we also know that it is not just only the outer blood retinal barrier, it also is a hot seat for melanosomes, for visual cycle, for immune privileged cases, and also a hot seat for various diseases, that is chorioretinal diseases. And this concept is borrowed from retroillumination of the slit lamp, which specifically sees the cases in front of the iris. So it uses 4 lasers. It has 8 apertures, that is 5 confocal and 3 apertures. The specificity is that the apertures are laterally deviated. So it always absorbs the light only in the one direction. So these are the various advantages, that it is non-invasive, it uses infrared laser and can also be used in non-mydriatic eyes. So let's first see how the normal retina looks on retro mode. So this is the color photo and the OCT and the corresponding FAF photo of the normal retina. And on the retro mode, we only see the ribbon-like choroidal blood vessels, which is normally seen on the retro mode in a normal retina. So now coming to the various diseases. So this is a case of retinitis pigmentosa, the central involving. And on the FAF, you see the hyper and the hypoautofluorescence, while on the retro mode, you could see some diseased RP alongside, which is involving beyond the central area. Now another case of paravenous pigmentary disease. So in this case, on the FAF, you could only see some hypo and hyper autofluorescence, while on the retro mode, you could see that the whole of the RP is diseased with the prominence of the choroidal blood vessels, the large choroidal blood vessels inferiorly. This is a case of cone dystrophy. The center is involved. On the FAF, yes, the classical pattern. And in this case, retro mode was not much contributory, as it only shows the diseased retina in the central part. So now let's see the RP dystrophy cases, whether retro mode helps us in these cases or not. So a case of Stargardt's disease, on the FAF, yes, you could see the various hyperautofluorescent lesions throughout the retina, and on the retro mode, we could see that this disease pattern is not limited only to the posterior pole, but is extended much beyond. The case of pattern dystrophy, in which the FAF is diagnostic, but we could see that the whole of the RP is diseased beyond the central area and is totally swollen out. A case of Best disease, in which the central part is involved, FAF shows the classical hyper and hypoautofluorescence. In this case, the retro mode was not much contributory, as it only showed the block fluorescence in the central area. Now coming to the other macular degenerations like dry AMD, this is a case of moderate dry AMD in which FAF is not much contributory, but when we looked at the retro mode, we could see there are swollen vesicles all over the retina, prominently which was corresponding to the color photo drusense. Okay. Another case, you could see these are the blisters which are seen all over the posterior pole and the prominence of the large choroidal vessels inferiorly. Now a case of soft drusen. On the color photo, yes, you can see these are the soft drusens. On the FAF, it is not much contributory, while on the retro mode, you could see the drusen is not only here, which are vesicles, swollen vesicles, but even in the periphery, you can see, that is beyond peripapillary area, you can see the blisters. Case of cuticular drusen. Similarly, FAF is not contributory, but yes, on the retro mode, the whole of the fundus is full of vesicles. A case of drusen plus pigments. It is a case of a 70-year-old male where you see that there is some pigments over the macular area and you suspect that it is because of the AMD. But when we did the retro mode, the whole of the RP is unhealthy. And when we looked at the other eye, The RP look unhealthy means it is something is going on in the RP and it can be a cause of AMD. A case of dominant drusen. In this color photo, you see that drusens are only parafoveally temporal to the fovea. FAF, yes, only the lesion is seen temporal to the fovea, but on the retro mode, besides this, the whole of the posterior pole is full of the drusens. A case of PCV, when we did, there was a fluid on the color photo and the OCT. Octa picked up the lesion. FAF showed some hypoautofluorescent, and in this case, the retro mode was not much contributory. We could see few lesions in the periphery, but it was not much contributory in this case. When we looked at the infective pathologies in the toxo scar, the central involving, so it only showed the blocked fluorescence because of the RP unhealthiness. A case of choroiditis, yes, the peripapillary choroiditis, we see the FAF showed some hypoautofluorescence, and on the retro mode you could see only the prominence of the choroidal vessels in the diseased area. This is a case of retinoschisis in which this is a color photo and OCT, and on the FAF it was not contributory, and even on the retro mode you couldn't find anything else. So a case of CSCR, there is the fluid of the macula, and we could only see few deposits in the periphery with the fluid blocking the underlying choroidal pattern. This modality is most important in diagnosing the difference between the VKH and the CSR. If we see a case of a VKH, we could see that the whole of the RP is bumpy and unhealthy, it's swollen kind of appearance which we could see. So if you are not sure whether this is a case of a CSR or a VKH, this modality can help you in differentiating between while doing the retro mode. Another case of posterior VKH, in which you can see on the retro mode, the RP is totally unhealthy, while in case of the CSR, RP is usually healthy. So this is the case of idiopathic choroidal folds. On the color photo, you could see the band-like prominences over the posterior, over the macular area. But in the retro mode, you could see the ribbon bands which are more prominent and more clearly observed. So with this, I end with the case series, and this is the limitation that it is only available in the F10 microscope. At present stage, it cannot replace the other modalities. We cannot detect the disease activity of CNVM on retro mode. Mechanism behind it cannot be described fully. We cannot differentiate between the flat PD and the RP irregularities, and it cannot localize the exact depth of the lesion within the retinal layers. Thank you so much.
Thank you, Dr. Shilpi. For this, just for the sake of the audience over here, we have different ways of looking at retinal pigment epithelium. The cross section, when we get to do it with the OCTB scans, where we can understand the anatomical part of it. Then the other way of looking at retinal pigment epithelium layer is to do a fundus autofluorescence. Fundus autofluorescence has a lot of limitation because you could see, if you see the comparative pictures between the retroillumination versus, you get a very limited information on which we have to make our diagnosis, base our treatment. In a retroillumination, it adds further to this. Actually, each cell of retinal pigment epithelium which is diseased looks like a blister, and you can actually substantiate it. And in many of the diseases where the predominant involvement is of the retinal pigment epithelial layer or a secondary involvement of RP because of a choroidal disease, those RP disease cells stand out much more better. You can quantify them. You can in fact see the areas of involvement in a better way. So it is adding a new way of looking at retinal pigment epithelium diseases, rather I should say. It's a new modality of treatment. We really do not know the information which this modality is giving us. We are trying to analyze and understand how it can be put to clinical utility with the confidence that this is what it means. That's it.